And it's really a pleasure and a privilege to be speaking from the AI and CAD forum. Let me just share my presentation so that we can start working this. So I think I have, yeah, somehow. So I hope everybody can see the slide now and can hear me well. It doesn't matter if you really see me or not, but if you can see the slide, be able to hear me clearly. As I've been introduced, I'm Adnan Aslam. I come from the twin cities of Rawalpindi and Islamabad. Islamabad is the capital of Pakistan, and it's a beautiful place to live. So we're going to talk about sinus lift, which is really one of the commonest augmentation procedures that we have to do while placing implants. And we're going to talk about a little evidence in sinus lift. And there's been lately a lot of new procedures that have come of age, new materials, new instrumentation. But we're going to look at the classic sinus lift, which has been taught forever. If that was a reliable procedure, or do we need to do something extra? So during the course of this presentation, we are going to talk about the basics of the external sinus lift procedure, basically, which is going to be really the crux for today. And I'm going to very briefly touch on the internal sinus lift, but as an oral surgeon, I really think that larger and more significant sinus lift procedures can only be done through the external pathway, and also discuss the important aspects for the success of the sinus bone graft, and in the meanwhile discuss the common controversies or common contentious issues, as I call them, that come to light when we talk about sinus lift. So the issues that we plan to discuss would be when to do an external lift, when to do an internal lift. If short implants, that again is something that has become very popular of now, are they equally good as a sinus lift with longer implants, for example? And when you have to make a choice between a bone graft, does it really matter? Does autogenous still form the gold standard for putting in the sinus, or do we have other options? Again, something which is very popular, the platelet-derived fibrin. Is there an evidence for using it within the sinus? Again, talk about the piezo surgery, and again, it's become very popular in sinus lift now. What to do with the bony window that you make while entering into it? What do you do if the membrane perforates? Does it really matter if you perforate the membrane a little or a little more? And finally, once you've grafted the sinus, do you need to put a barrier membrane on the side of the osteotomy? So something very basic, the classic Harvard and Howell classification told us that as soon as the tooth was lost and there was accordingly a pneumatization of the maxillary ridge, it would tend to get occupied fairly quickly by the maxillary sinus. So there were procedures that were described, whether you could place an implant directly or whether you wanted to do an augmentation. You would want to do an augmentation, whether you would want to do an adjunctive soft tissue procedure, and it really depends on what we call as going to be an important aspect for today, the residual bone height, which will make you decide what you're going to do with placing an implant in the posterior maxilla. And then again, there's another classification. So you can clearly see that in the SA1 type of residual bone height, which is quite reasonable, which is about 10 to 12 millimeters, you can place an implant directly. But in SA2 or SA3, you can think about doing an internal lift, and in SA4, there is no other option but to possibly go for an external sinus lift. Now, there can be a lot of variation in the human jaws in the terms of how much the sinuses occupy the maxillary and lower ridge. And these are two similar patients of the same age. Both are almost completely edentulous. Um, he's partially edentulous and he's completely edentulous. But you can see that there's a lot of bone and there's really no need for doing a sinus lift. And you can come and you can do 6 to 8 implants without any problem here. But in this sort of a case, you can see that there is resorption, which is more in the vertical plane, so there's no alveolus really. But there's a very large sinus that is pneumatizing, that is filling up the whole of the alveolus here. So obviously in this kind of a case, you do not only need to do a little bone graft here, but also possibly put something on the top here. Otherwise, you risk making a very long prosthesis and risk cantilevering the whole thing. So when we talk about possible implants in the posterior maxilla, you need to have adequate bone stock, bone quality. You can do conventional implants. This is typically something which is 10 millimeter or more, and a thickness of about 5.5 to 6 millimeters or more. But where you do not have adequate bone stock, you can possibly avoid the posterior maxilla. Excuse me. You can do 2 implants over denture, but we know that even by placing 4 implants and giving an overdenture on the maxilla, you still need to have at least some extension onto the palate. And one of the reasons people would be looking for implants in the maxilla would be to eliminate that palatal extension of the denture that they generally have. So, and the other option is all-on-4, and it's also become very popular of late. You need to have a very nice lap support. It's more of a prosthetic-driven concept. There are now issues which are emanating, which basically think that if 4 implants are enough for an all-4 immediate loading hybrid prosthesis, and whether it's all on X or is it all on 4, and we do not know right now with impunity what kind of an optimal number of implants do we need. So X can be 5 or X can be 6. So all on 4 is popular, but then people have started doing it with more predictability with all on 6 implants. So one might think that if you're placing 6 implants, do a hybrid prosthesis, you might as well place 7 or 8 and do a fixed bridge. And then obviously you can do onlay bone grafting, but vertical onlay bone grafting is typically tedious and has a higher risk of wound dehiscence and opening up. You can do a fourth one down fracture and interpositional bone graft. We've done this in a few cases, but again, it's not something that we are planning to discuss today. And then obviously sinus lift, which is very common. And the last thing that we can do is possibly insert a zygomatic implant here. Now, if you look at the sinus, and this is a coronal section, so you're looking at the sinus from the front. So you can see that the sinus is a pyramidal shaped cavity, which has a length and a height, and obviously there's a width. And it's closed in all sides, except there's a little opening into the lateral wall of the nose, which is really in the middle meatus of the nose. And this little opening is called the ostium of the maxillary sinus. So the sinus is lined with soft tissue, which is typically called Schneiderian membrane. Now this is on the inside, is basically pseudostratified ciliated columnar epithelium, and it produces a lot of mucus, and the cilia that are on the inside of the mucosa tend to drive all the mucus out from the sinus into the ostium. And if you have, for example, a blockage here, you would not want to do a sinus lift because there will invariably be inflammation. There will be more secretion of the mucus. The mucus will become thicker and it will not get secreted. It will cause symptoms here. So this is important. The ostium has to remain open at all times. And as we'll see in our post-operative instructions, keeping up the ostium open post-operatively is very important. So the key points when doing sinus lift, as we'll continue to see, because this is a key area, is the integrity of the sinus membrane. We see that it's 2-layered thick. There's again the respiratory epithelium on the inside, and then there's the periosteum on the outside. And if you're able to reflect the periosteum nicely from the bone, and which can be very thin in a few cases, you will not have a risk of rupturing or perforating the membrane. So typically the periosteum is very thin, so once you perforate this, the membrane also gets perforated. Um, uh, if the sinus lining is reflected very well from it, it is a very nice periosteum, which is very nicely osteogenic, and we'll see that bone grafts tend to work very well in the sinus lift or the sinus bone graft more than anything else as an augmentation procedure in the implants, because of the very rich osteogenic potential of the maxillary sinus lining. So one might ask a question that why do you do a sinus graft and why not place implants into the sinus? So the first thing is that if you do not have enough bone here and while placing implants here, you do not get enough primary stability, and typically you need to have good primary stability with predictability if you have a residual bone height of about 4 to 5 millimeters. Now, if you do not have that, if your implant keeps moving in the healing phase, it's not going to get osseointegrated. Plus, if there's a lot of projection of the implant into the sinus, there is again a risk of causing sinus disease, acute inflammation, which can become chronic inflammation, chronic sinusitis, and is typically a problematic condition that would require sometimes pharmacological, sometimes surgical therapy to get rid of. So, so you can possibly enter the sinus 2 or 3 millimeters without doing a sinus graft. But anything more than that, and if you have a residual bone height, anything less than 5 or 6 millimeters, you need to think about doing a sinus lift. The sinus lift is an often very popularly talked about procedure. Dr. Jensen is considered to be an authority in sinus grafts. There are complete textbooks now written on sinus bone grafts. So this entails on the importance of what kind of procedure it is. Coming back to the sinus lift, there are basically 2 kinds, and the one that we're going to talk about today is the external, which is also known as the open sinus lift or the lateral window sinus lift, or then there's the crystal bone approach, which is also known as a closed approach or an internal approach. This was described by Professor Hill Tatum in 1974, and about 20 years later, the lesser invasive and the quicker procedure was described by Dr. Summers in 1994. So in order to do a closed sinus lift, you need to have at least a 4 to 5 millimeters of residual bone height. And the kind of predictable elevation with internal lift is about 5 millimeters to 6 millimeters. Anything more than that, you need an external sinus lift. There have now been reports and there have been case series in which people have been able to lift 10 millimeters or 12 millimeters with an internal sinus lift. Because most of these would be possible but are not reliable, they are not predictable. And some of these surgeons might be very talented and they've spent all their lives doing only one single closed sinus lift procedure. So this tends to work very well in their hands. But we are going to talk about evidence. We're going to talk about a procedure that should work with reliability and with predictability in the hands of anyone who would do it well. Not something that would require miraculous qualities and miraculous ability to do so. So if you have to do internal sinus lift, you need to have a residual bone height of about 4 to 5 millimeters, and you can raise it further to about 5 to 6 millimeters, ending up placing an implant of about 10 to 12 millimeters of length, which is an acceptable length when you're talking about posterior maxilla. So in an external sinus lift, you basically make a window on the on the lateral wall of the maxillary sinus, and this is typically about 3 millimeters from the residual bone height level, 3 millimeters from the anterior margin of the bone, and about you can go anywhere on the posterior, because you don't need to raise the whole of the posterior maxilla, because there's no point in making the sinus lift complicating and doing a lot of membrane reflection in the third molar area, for example. And then this window height is about 8 to 10 millimeters in height, and there is a reason why you should not go beyond that, as we'll discuss a little later. So once you have made that window, you very carefully dissect the sinus lining, first from the easier portion, which is the posterior portion, then from the anterior portion, then a little from the top, and then you eventually go to the bottom, which is really the area which is your area of interest. And once you have done that, you reflect it from the floor, and then you go to the medial wall, and once you have reflected it properly, you can put the bone graft in there. Now, there can be a contention that you might not have to reflect on the medial side. Let me change the color of the pointer, something brighter. Okay. So, like in a midlife crisis, you get a red Porsche. I have a red pointer here. So anyway, you need to reflect the membrane from the medial aspect also, because if you do not do this, there is a risk of during the healing time, the membrane, the sinus expanding and filling this up. So you need to make sure that you have good space maintenance while the graft is healing. And once obviously the graft is healing, then it won't go anywhere. And then even if then there is resorption, it's a very slow process. So the other procedure is the internal lift. We typically go up till about bottom of the sinus, and then you take an osteotome, which is called a sinus lift osteotome. You fracture it, and then you can take this inside very gently. You need to go, the key is to go with as thick an osteotome as possible. So probably the thickest osteotome that you have before the implant that you're planning to insert should do. And obviously there are many alternatives and many non-invasive alternatives that have been described now, but they might be less morbid for the patient, but the kind of success that we have with either or the hydrostatic balloon or the cutting guides or anything would be similar with osteotome technique or the newer methods. So this is a typical patient. We drilled and we thought that there was a little cortical resistance here. So we stopped here, did an X-ray. We found out that the bone was still about 1.5 to 2 millimeter here, and it's very difficult to fracture it here. So then we went in a little more, and then we found out that we are really at the floor of the sinus. And it's interesting to know that out of all the walls of the sinus, the thickest is the floor. So you would require considerable force. So in order to avoid doing a lot of force, you need to make sure that you are very thin at the floor. And then obviously you keep, you enlarge the opening, and once you've enlarged the opening, you can do your sinus lift. And a typical internal sinus lift success at the end of the procedure is typically shown by this little mushroom-shaped bone graft that kind of conforms with the surrounding of the apex of the implant. So you know that this is going to work very well, and there is no splaying of the bone graft, no splattering of the bone graft within the sinus. Or similarly, another patient in which we placed an implant here, and then we did an internal sinus lift here. So it looks a little more bone here, but you can see that we were able to raise quite a bit of about 4 to 5 millimeters of bone here. And this is at about 3 years. The patient had gone abroad. So when she came back and she didn't have her crown, you could see that there was a very nice homogeneous bone formation around the implant. And I think one of the key features in which you can tell if the bone graft within the sinus is integrated with the rest of the bone is the lack of cortical outline here and the new cortical outline on the top. Similarly, another patient in which we did 2 sinus lifts concomitantly, and then eventually you can see that this is at the time of the 2nd stage. Similarly, another patient in which we did an internal sinus lift, and you can see that there's a new cortical outline here. This is 5 years down the road. This was a tissue level implant, so there's no bone loss, and it looks well enough because the bridge height is quite acceptable. Now, can you do implants and can still get away without doing a sinus lift? Now, most of the studies tell us that in about 50% of the patients who have absent premolars, the bone is deficient. And whenever we talk about deficient bone in the premolar area, we're talking about anything less than 8 to 10 millimeters. So you can come back and you can do a short implant, but that's another story. So in order to do an optimal placement of an implant, which is about 10 millimeter or long or longer, you need to do the sinus lift in about 50% of the cases of premolars that have already been removed. And in about 80 to 90% of patients at the level of molars. Now we are doing a study, and one of our colleagues is doing an MPhil anatomy study to find out what would be the percentage of our population who would have deficient bone at the premolar area or the molar area in terms of the edentulous patients. But this is the Western data, and I think our data would be similar, if not the same, to this. So you can imagine that in order to place an optimal implant in about 80 to 90% of patients at the level of the first molar or the second molar, you really need to do a sinus lift, which is quite a large number. So you cannot do without it. So you can possibly do this at the fibrosity, which is very soft bone, and this is unnecessarily prolonging the length of the bridge, cantilevering this unnecessarily. But you know, talking in the era of the prosthetically driven implants and prosthetically driven implantology, you need to place implant where you need the prosthesis really, and this is the first molar area. Now the sinus dimensions have been shown to be about 10 to 15 millimeters in many of the older studies, and this is a relatively newer study which has been referenced in a newer study, but this is an older study which has been referenced in the same. So I went back and did that, and it is about 10 to 12 millimeter of volume. And typically, if you have to do external sinus lift, you have to take away about 1.5 to 2 cc of this volume. It is possibly a little important for you to know about the volume of the sinus so that you can estimate the kind of bone graft requirement that you have. So we'll talk about this a little bit more detail. The contraindications to sinus lift would be anything that is really any process that makes surgery contraindicated, such as radiotherapy or people who have been on bisphosphonates or people who have been on, again, other types of anti-resorptive therapy to the jaws, or if there is sepsis or if there is severe medical compromise, uncontrolled systemic disease. And then there can be local, more of a temporary contraindication, which can be an empyema that once it resolves and you wait for sufficient time to come back and do a sinus lift. Or in a patient with chronic sinusitis, which can be treated by an ENT through, again, pharmacological or invasive methods, and you can come back and you can do a sinus lift. And we'll see a couple of cases with these two also. Now, are sinus lifts predictable? Now, there's a huge data, and there have been many meta-analyses that have been done on the predictability and the success of sinus lifts. And generally, most of these reports show that sinus lifts have been proven to be successful in more than 90 to 100% of cases, which is quite huge, which is very reliable. You would not have this kind of a data, for example, for wrist fit or the GBR or even the titanium reinforced GBR. So possibly nowhere in implantology an augmentation would work as well as this kind of case. It might work similarly in a socket preservation. But in a socket preservation, there are other factors you might not have needed the bone graft anyway. So anyway, in order, so most of the success of the bone graft has been attributed to when the implants that have been used have been of a tapered design rather than a straight design, because this kind of gives you that nice primary stability, which is important for good osseointegration. Porous surface implants are obviously a thing of the past for most of us now. So it has to be, again, the reference surfaces implants, and you can have the titanium plasma spray or the acid etched or the fine grit sand blasted, any sort of a reference surface, but most of them would work better within sinus. And one of the most important factors of success in a sinus lift is the amount of bone that you started with. So if you had to start with about 5 millimeters of more bone, the success rate has been shown to be 96% or more. But it comes down about 10% when the resultant bone height is 4 millimeters or less. Now, this is an important factor for you to know. And this, whenever we talk about a very high success rate, it's both for the bone graft and the implant. So obviously, if a bone graft works very well, the implant has a higher chance of working. So in either case, the implant works as well because there are studies that show that implants work as well in a sinus lifted area as well in a natural bone. This is the kind of reliability that sinus lift has for both bone graft and for implant. You can see that one of the indicators is marginal bone loss. Primary stability is important, but second stage success is also equivalent, and also long-term marginal bone loss at 5 years has also shown to be statistically significant between if the implants were placed between sinus grafted bone or native bone. There has been just a slightly higher, about 5% difference in biological complications in patients who had had a sinus lift, and these biological complications have actually been related to the sinus, which has been acute sinus disease or chronic sinus disease, but that again has been really, it is significant, but it's not something that should, kind of prevent you from doing a sinus lift. If you have to look at one factor, you need to reinforce that the most important factor is membrane integrity. You need to spend time, you need to do it well, you need to do it very, very patiently, you need to do it very slowly. Membrane perforation is clearly the most important indicator whether a bone graft and subsequently an implant would work in a sinus graft. And there are question marks. People say that if you salvage it properly, and obviously it depends on if you have a small perforation or if you have a large perforation, but it is contentious. Once a perforation, it will cause something. So as we can see data that there is about a 3-fold larger chance of graft failure in perforated membranes. So if there was a graft failure rate of about 4% in the intact membranes, there is about a 12% failure rate in perforated membranes. There's a large chance of sinusitis, there's a large chance of antibiotics need post-operatively if you have membrane perforation. 5 out of 6 cases who would have sinusitis after the sinus lift would be those in which you have perforated the membrane. So generally, if a membrane perforation has to occur, it generally occurs in the anterior region, but it can also occur in the middle. Generally, because of the axis and also because the membrane is typically a little thicker in the posterior zone, there's less likelihood of a membrane perforation in the posterior area. Now, in case a membrane perforation occurs, what do you do? So you need to estimate if it's a small perforation, or if it's a medium, or if it's a large perforation. So the sizes typically are 2 millimeter or less for a small perforation, 2 to 5 for a medium perforation, and more than 5 millimeter for a large perforation. So for a small perforation, first of all, you need to ascertain that as soon as you've seen a perforation, you would know that you have caused a perforation. So you might not tell your assistant that you have a perforation, but you know for sure that you have a sign that you have a perforation. You need to become really careful. You need to make sure that you need to go around the perforation, and you need to deflect the sticky membrane around the perforation, which is very important because typically you start off with a small perforation and then you get a little unnerved and you try to do it a little quickly, or become a little anxious and then end up making the very tiny perforation into a very large perforation. So in a small perforation, the first thing is to, you can actually see it here with a very tiny perforation here. So you need to make sure that you go the inferior anterior aspect, the superior posterior aspect, and then around the perforation so that you know that it's not being magnified by you taking the sinus lift elevator inside. So if you do this, and in this kind of case, you place an implant, you can see that it's integrated quite well. Similarly, another patient in which we had a perforation, and this perforation actually occurred because of a sharp end of the window that we had created, and this typically occurs in patients who have very thick bone overlying the sinus. Now there was no perforation, but as soon as we started putting the graft, we realized that we had a little tiny perforation here, and we didn't think that we would need to cover it with the membrane. Anyway, I do not prefer to use a barrier membrane on top, but this is what we did in this case. And you can see that you can see it clearly is that there's literally no bone here. But post-operatively, we had a large amount of bone here because there was a large elevation here. And then when she came back, there was good bone formation here, and she had come back in about 2 years because she had gone abroad. But the patient, in the meanwhile, while she was in Canada, had a large bout of sinusitis, which was managed with decongestants and antihistamines and no antibiotics, but it eventually settled down. So you can see that there was a very tiny perforation, and this is as tiny as this. There was something post-operative. So the risk factors for a perforation would obviously be membrane thickness. There are people who have very thick membrane, as much as 1.5 to 2 millimeters of thick membranes. There are people who have membranes as so bubble. So those cases are generally not very good candidates for sinus graft. If you think that there's no way you can deflect the membrane nicely, and this typically would happen in about 1 out of every 10 cases, it might be prudent to avoid a sinus lift. There are many people who think that you can really tear the membrane big time, and then you can take the magic wand, the Amrit as we call this in Pakistan, and you can put this in the sinus, and the PRF or the magic wand would create a miracle inside and would start to make bone. Now that's not the case. You need to basically reflect the membrane nicely. It's basically not because of the PRF that you have bone there. It's because of the nicely reflected periosteum that you form bone here. So in very thin membranes, typically about 10% of patients in which you have multiple perforations while creating a window, it might be prudent to avoid doing a sinus lift and then think about an alternative procedure. If there are septa within the sinus, that's also a risk factor. If there are presence of teeth, that's a major risk factor because on the top of the roof, the sinus is not typically very leveled, and I would prefer to do an internal sinus lift rather than an external sinus lift in these sort of cases. Now, this was one of those cases in which there was a small perforation because we had to do a sinus lift on top of the premolar also, which was also extracted, and then we had to do it here also. We were able to place an implant because there was good primary stability here, but there was no interradicular bone really here, so we could not have placed an immediate implant. So we came back and placed an implant later on, and you can see that this is again, this is about 8 years post-op, and you can see that the bone graft is staying very well. So the key was a very tiny perforation, which is less than 2 millimeters. Typically, when you elevate this folds itself. Even if it does not fold itself, it's so tiny. You just need to make sure that there is no foreign body entry into it. Surgeons suggest that piezo is better over rotary, which is really the procedure that I use, and we'll talk about this. I think the key feature again in preventing a membrane thickness is extreme patience. I think this is the single most factor. There is no other procedure in the oral cavity that I would do dead slow. I mean, you can do fast wisdom teeth, you can do fast periapical surgeries, you can do even fast GPRs, but you cannot do fast sinus lift membranes, especially in those membranes which are a little thin, or where you have septa, or where you have, adjacent teeth close by. Now again, you can see a case example, patient who's partially dentulous, completely dentulous in the maxilla, and you can see that there's a dip down of the maxilla, and there's nothing that you can do on the 6th, as we were planning to give the patient a complete prosthetic option here. So we made a window, and then we started reflecting it, and then we had a little rant here that was 2 millimeter, but then we increased it to about 4 to 5 millimeter. But the key really is to make sure that it does not become large. So you need to go around the perforation. You need to make sure, you need to check yourself, and then you make sure. And then typically you'd need the micro needle holders, the Castellio needle holders to actually do a repair. As you can see, the little repair that we did with 6-0 Vicryl on a micro needle holder, because the conventional needle holder, even 5.5 or 6 inch, would not go inside and would allow you to repair it. So anyway, we did this, and then we came to the other side and we did the relatively cleaner, better uh, sinus lift on the other side, scrapped both of the areas, and then we were able to place the implants when this healed. And you can see that there's very nice bone here. There's a little less bone on the perforated side, but we were able to salvage it somehow. And then the patient had other implants on the man, etc. So again, a very interesting topic for today, PRF or no PRF. Is it the PRF which makes bone after the membrane reflection, or is it the very nice osteogenic environment? So you can imagine that you have bone on the undersurface, you have bone on the medial surface, you have bone on the top. If you have taken the pendulum side, you have bone anteriorly and posteriorly. You do not have any bone on the lateral side. But once you have taken back the flap, there is periosteum on the lateral side. So everything is richly osteogenic. Do you really need to insert a PRF inside? Does the PRF take the credit for a very nice osteogenic environment? So there's a very large meta-analysis that has been done comparing PRF versus the regular bone graft, and we can see that the survival rate for the implants, there's new bone formation, the integration of the graft with the rest of the bone, the complete resolution of the residual bone graft, the soft tissue entrapment into the graft, everything was comparable. But then there are studies between PRF and no bone graft, and you have equivalent results. So again, it is not important to do a PRF. It's important to base the membrane very well. I prefer to do a bone graft because this gives me space maintenance, as we'll discuss a little more in detail. PRF does not do a space maintenance. So if you are putting an implant, you might put PRF inside, or might not put anything. There's a very large case series that has demonstrated that only by reflecting the membrane nicely and using the implant to do a denting of the lining, you should be able to have comparable results. So the problem is that when you have residual bone height is not much for an immediate implant after a sinus lift. If you have done, for example, a 12 millimeter of raise and you do not put anything inside, or for example, a PRF, it would gradually come down because the space maintenance would not be done by PRF or no PRF, for example. So this is an interesting case. This patient, and I think I do not have the X-ray here, but the X-ray will come in the next slide. So we made a very nice window, and there was literally no bone here. There was about only a millimeter of bone here. So we made a large window. And typically, in this sort of a case, you need to start with the easiest reflection, which is on the posterior, followed by the anterior area, followed by a little bit of about 3 to 4 millimeters on the superior side, and eventually then starting from the anterior inferior and the posterior inferior area, and then starting the reflection, which is so most important area is this, but you come to this place at the last. So you just need to make sure that the membrane is a little released and it's not very tense when you go to this area. So anyway, after you've done this, you can reflect it nicely, and you need to make sure, and typically the more you reflect the membrane, the easier it becomes for you. So initially you are a little tight, but as the more it opens, the better it becomes. So after we raised it, we realized that we do not have enough bone graft. We only had about cc of bone graft, and this was a large sinus lift, and we needed about 2 to 2.5 cc of bone graft. So what do? So we thought that we might not have to do an implant on the upper 7 region. So the crucial portion is the upper 6 region. So we'll have this filled with an allograft, which is our material of choice. And we'll put this, we'll fill this up with a gelatin sponge. So this is what we did. So you can see that we have the allograft here and we have the simple gelatin sponge here. So this is in the context of a PRF. So there's no PRF. The growth factors would only be growth factors that would be derived from the blood that has been trapped into this gelatin sponge here. And this is again one of a very common thing that we insert to minimize the bone graft requirement in unnecessary areas such as over the third molar area, or in tiny recesses. So anyway, so we see this patient later on. You can see that preoperatively, there's just no bone here. There's complete sinus here. So you can see that this is immediate post-op. The patient was wearing large earrings, so there's a distortion here. Then we asked her to take off the earrings and the 6 months post-operative X-ray. And you can see that there's very nice bone, and there's equal amount of bone graft on the allograft side and on the gelatin spawn side. So again, you question yourself if it's the environment, or if it's the bone graft, or if it's the PRF. But then PRF does not space maintain. The bone graft at least maintains the space there. So we came back and we did an implant, and this is at the time of implant healing, and you can see that there's very nice soft tissue, a large keratinized tissue around the implant, and you see that there's very nice bone around the implants. Coming on to the next contentious issue, which is the use of short implants. I think I need to hurry. I thought I'll finish in an hour, but I went into a rabbit hole when we're talking about the membrane and the DRS. So people have started to like short implants. This is an implant which we placed 10 years ago. This was a Straumann 5.5 to 6 millimeter. The patient dropped the idea of having any more implants. So he came back after about 6 years after placement of the implant, and the implant was still going strong. And this is a 5.5 to 6 millimeter of an implant. Now, there is insufficient evidence if whenever you say a short implant, it's typically less than 8 mm. Whenever you say a longer implant or an optimal implant, it's more than 10 millimeters. So there is insufficient evidence to compare short implants without sinus lift, longer implants with a sinus lift. That what is better? They are equivalent in short and medium term, but it would be very interesting to see if we have long-term studies, because if you, for example, put a 6 millimeter implant and then give a 12 millimeter of prosthesis on top of it, the vertical cantilevering would be just huge. So the main advantage of doing a short implant is to minimize the biological complications because of sinus membrane perforation and because of sinus lift. So I would be very skeptical in using short implants routinely. They tend to work very well, as the evidence suggests, in the short and the medium term. But you need to remember that these implants will come to you after 5 years, then 7 years, then 10 years, and it's never a good feeling seeing an implant fail, even long term. Coming between rotary versus piezo, piezo has an advantage over rotary because there's about 3 times less risk of perforation of the membrane. I use piezo for everything else, for my orthognathic, for on-limb bone graft, for wrist splits, for everything else. But for some reason, since rotary was working very well, and if something is working very well in my hands, I would not want to try a next procedure just for the sake of it. So yes, piezo has a lesser risk of perforating the membrane, but then I feel that generally you would not have the membrane perforation, or you would have only a very tiny membrane perforation when making the window. The game changing is basically when you reflect the membrane, and the better membrane reflection you do, you do a very nice piezo, and then you do a careless reflection of the membrane, you still are going to perforate it. So this is my take. I think it's how you reflect the membrane which is more important. But yes, statistically and in the evidence, there is evidence that you have piezo. Rotary works very well in my hands. You should try whatever works well on your hands. Very membrane, there are many people who like doing it. We don't like it because we think that it forms a barrier between the very nicely. If you've raised a nice mucoperiosteal flap and you have intact periosteum underneath the flap, and if you suture it back well, a watertight closure at the end, tension-free watertight closure, it should do very well. And generally there's no soft tissue entry into that area. So again, there has been a very large meta-analysis, including about 37 studies combination. Started off with about 600, and then they found out that what are the randomized control trials, and they found out that there was similar vital bone formation in both of the groups. Put a membrane or you do not put a membrane. We do not put a membrane because we think that it's kind of might have a prohibitive effect on the periosteum because it comes between the periosteum of the flap and the bone graft. So what should be the graft form? Block is generally considered to be better and has better evidence than particulate, which is equivalent to the putty form, the demineralized bone putty, as it is called. Blocks are not available in allografts. Autogenous blocks are hard because it's difficult to convince patients most of the times, and when you have alternatives, you not want to go for this kind of thing. So whenever we talk about the graft, and generally there's almost a consensus that the autogenous graft is the gold standard, but then allografts or xenografts or alloplasts have an equal amount of success in the sinus, and really there's again many meta-analyses, and none has been shown to show that something is better than the other. Autogenous is slightly better, but if you mix autogenous with xenograft, which is again a very popular method, it is slightly lower than autogenous bone graft. But then obviously xenograft or allograft is slow resolving, so you possibly need a bit of that, and you need a bit of nicely osteoconductive, and osteogenic part. So osteogenesis is only osteogenesis and osteoinduction is only through an autograft, or if you use BMPs with an allograft or a xenograft, for that matter, an alloplast. But when it comes to the sinus, the environment is so richly osteogenic that almost everything works. We have used autogenous bone, we've used allografts, which is really our choice now. We've used xenograft, but if we have to choose between an allograft and a xenograft, so obviously we'd like to use a human source. The European studies are all with xenograft because they are not allowed to use an allograft. So if we have really both of them available, and there's not much of a price difference, why do we need to use a xenograft? There's a very interesting paper that has just come out from Switzerland, and there's recently been a lot of fungal ball disease, aspergillomas with xenograft in sinus lifts, and this is an interesting study, so you can take it out and you can look at it. And this is, by the way, with BioOS, which is considered to be the gold standard xenografting material here. It's the sinus which provides the best osteogenic environment. We would need to have something that is osteoconductive, which can be allograft or a xenograft, but ideally should also be able to maintain the space, especially if you're not doing the implant. But everything works within the sinus. It's a magical place. I'll see if I can play this video. Okay. Options. Arrow. So obviously, once you have made the window, you can see that the patient breathes, and you can gently press on the same side nostril, and that elevates the sinus lining very well. And if there is a moderate to severe perforation, it would not get lifted. It would still get lifted if there's a tiny perforation because the amount of air drawn is still too much. But if it's a moderate to large perforation, it would not get elevated. To graft or not to graft, whether to put PRF, whether to not do anything, depends on really you're doing the implant. You can be brave enough and just do an implant with PRF or without anything, but you need to have a residual bone height of about 5 mm so that you can have an implant base. How much bone graft do you need to put this? So typically for a 10 mm lift, you need something like 2 cc of bone graft. So this should be your estimation, that if you have to go about 10 mm high, you need to have about 2 cc of bone graft. Tiny areas are generally better for internal lift, but they also form nice places because you have little bone here and you have little bone here. So you have nice margins on which you can lift up the sinus. So we went back in. And if you have a lot of bleeding, you can put gel foam temporarily, and this kind of rest bleeding, and then you can put bone graft. and come back. So this is post-operatively, immediately post-operatively, and this is at the integration of the implant here. And these implants have been placed by someone else, but but you can see that there's a very nice integration of bone graft here, and there's a new cortical reformation, which is really the key of a radiographic key of a good bone formation. What should be the sequence if you're placing an implant immediately? So you need to have at least 4 millimeters of bone so that you can have primary stability. So you do the window, you lift the sinus, then you do the drill, whatever is the drill, and typically you do an under drilling, but you drill till wherever till the point that you have to. Then you put the graft, then you insert the implant, and then you, since some of the graft would be displaced, you can tap the graft again. If you lift the sinus and put the graft first, as soon as you start drilling with irrigation, the bone graft would be lost. Similarly, if you put the bone graft before, after you have taken in the implant, you have the risk of touching the implant surface, which is showing in the sinus lifted area. So this is the sequence that I like, that you lift the membrane, then you drill complete, then you graft, then you insert the implant, and then you reposition the graft again. This is again at the post-operative result, and you can see that there's a nice cortical bone reformation, very nice bone graft there. So posterior superior alveolar artery vascular complications. So typically in cadaveric studies, it's been shown to be at a distance of about 15 millimeters on the molar area, about 20 millimeters on the premolar area. So you typically not, wherever you have to make your inferior cut, you try not to go more than 8 to 10 millimeters here. We did not believe in the reality of a posterior superior alveolar artery till we cut one, and then it was very difficult. You can control it. It can be very large. You can still control it if you do not mind perforating the membrane. So you cannot apply a lot of pressure. So we used basically cautery and a combination of crushing the bone around the sinus, but it was quite large, and it took us about an hour to make sure that we have arrested it completely, and it was quite a problem. You can do a CBCT and it will tell you, but typically remaining something like 15 millimeters within the confines of the alveolar pressure should be all right. So this is afterwards, did not compromise our sinus lift result, and we had a nice bone graft. This is an example of mucocele. So once we made the window, we just aspirated this, and there was thick fluid. And then we did the bone graft. This was immediate post-op, and you can see this. And afterwards, you can see that there is no sign of a mucocele. We were able to drain it, it did not form again. Even if it forms, it reforms, and there is no infectious complication. There is not a problem, but you can see there is very nice cortical reformation here. We came back and did these implants that have been loaded now. If you do a good sinus lift and you have good visible bone height, we could have done internal sinus lift, but we ended up doing an external sinus lift. But you can see the amount of very nice tissue and thick collars that you're able to form if you have nice tissue here. Similarly, somebody who has a little septa here, so if in case of the septa, you need to make sure that you make a rectangular window here, and then take the window a little down on each side of the septa, so that you can do as much of a direct lift as possible. And once you do this, and you're able to see this bone on the mesial aspect of the second molar, and bone on the distal aspect of the second premolar, you have a nice area, and there's a little perforation of the periosteum, but the sinus respiratory epithelium is still intact. So we could put the bone graft, and we came back and we placed it in that. So this is immediate post-operatively. This is at the time of placement of an implant, about 5 months later on. Very nice bone that is formed, and there's a very nice cortical reformation here, and we came back and placed these implants here. If you have septate, one window would not work, so you need to possibly make 2 windows, and then you carefully reflect both of them together. So one of our windows becomes so small that we had to discard it. I do not take it off, because taking it off also runs the risk of perforating the membrane. If you do a piezo, you can take it off, and then you can put this back. I do not think that piezo would make it any different to me. And since rotary is working well, so I take the window bone inside unless I have to make this into 2. And if it's very tiny, there's no point in keeping it there. So this is afterwards, and you can see that there was very little bone here. There was about 3 to 3.5 millimeters of bone on each side, but the implants were placed immediately, and you can see at 6 months they have healed, both of them have healed very, very well. Large sinus lifts needed on each side, so large areas that were reflected again to exemplify. This is again gelatin foam, gelatin sponge, but treated with tannic acid. We do not prefer to use the tannic acid treated gelatin sponges because they are hemostatic, and we would want they to be absorbed into blood and not stop bleeding completely, and not be inhibitory to bleeding. But we, in both of these areas, we kind of stopped the second molar area with sponge stone, gelatin sponge, and we came back and we placed implants. And you can really see that there's really no difference between both of them. So why not do nothing, or why do PRF? It would not maintain space if you're not placed in implants. This is immediate post-op. This is at the time of the implant healing. Similarly, a patient on which we could do an internal lift on the left side, an external lift on the right side. So this is a tiny area. The smaller window you make, the more difficult it becomes, but I think just with patience, you can do it very well. So this is a very nice periosteum that you can see all around, and you know that this is almost a guaranteed success. If you see the periosteum, you don't see the darker, translucent, sometimes respiratory epithelium here. So this is the bone graft. We place the implant immediately, and this is on the internal lift on the left side. So this is post-operatively, and you can see that we have equal amount of bone. But since there was residual bone height, it's better here. Then external here and internal here. Now this, if this video plays, this is a patient who had chronic sinus inflammation. We ran a CT and did a CBCT, and you can see that we are running the CBCT, and so we do not routinely do a CBCT according to European directives. You have to, but generally we don't unless we see, for example, sinus disease on each side. We had seen this on OPG, the reformed OPG. You can see that the sinuses are almost completely filled with inflammatory tissue that you can see here also. So we sent the patient to an ENT who did not do any invasive therapy, just put the patient on pharmacological therapy for 2 weeks. And after 2 weeks, we came back and we did this implant on either side. You can see that the sinus is really filled with a lot of chronic inflammatory mucosa. We came back after the end of the pharmacological therapy, did the sinus lifts, and you can see that it's immediate post-op, and this is at 6 months post-op, and you can see that the sinus disease has lessened just a bit, and there's very nice bone formation on each side. So there's huge amount of bone, and there was a millimeter of bone on each side preoperatively. This is interesting. So you need to, if you're thinking about doing a sinus lift, you need to pay attention to this area, which is a little periapical lesion, which is perforating the floor of the sinus, going into the sinus. And as soon as we reflected the flap, you can see the gush of so there's somebody else. So anyway, so this was it, and obviously you do not need to do this. You need to come back and do it later. This is the last case. Patient with very flimsy, tiny membrane. We wanted to do 3 implants here. We could only do 1 because we knew that we had a perforation on the right side. Well, on the left side, we were more careful, but we still had a small perforation. We did a bone graft, and the patient developed a huge swelling post-operatively. And we started to treat the patient with antibiotics and nasal decongestant and antihistamines, but it were not working. And eventually, the patient had an oroenteral fistula, quite a disastrous complication. So what do? We started the patient with IV antibiotics, went back in, and the plan was to remove all the bone graft and take out the 3 implants that we had placed. But the implants were so tight, and we tried to do a counter movement of with about 15 newtons force, and we could not budge the implants. So we took a chance. We removed all the bone graft. We placed a new bone graft. We put a membrane, collagen membrane, on the floor of the sinus, and held it. And then we placed another membrane on the top of the bone graft, and then we took a little fat from the cheek, which is called the buccal pad of fat flap, and everything. So we've kind of sandwiched everything inside, and then we did a very, very meticulous closure, as you can see here. Post-operatively, the patient again had a little dehiscence, but kept giving the antibiotics, and eventually the buccal pad of fat worked extremely well. And you can see that there's very rapid mucosalization, and that was really the well-vascularized buccal pad of fat saved the implants, and all of these implants worked. So there was little less bone formation here, but all the 3 implants were integrated. And guess which implant failed? This implant that we never thought would fail actually failed in this kind of case. So this brings us to the end of the presentation. I'm still 3 minutes overboard. You need to make sure that the ostium is open. The patient should be able to breathe through the nose. You need to prescribe the patient, if you take the implant a little into the sinus, if you do internal sinus lift, you do external sinus lift without a bone graft, with the magic wand, which is PRF, or anything, you need to give them antihistamine, anything, cetirizine or loratadine, or anything that you like. A decongestant, typical is pseudoephedrine. If the patient is not a hypertensive, it does not have cardiac disease. But you try to give them, especially the decongestant, for a limited time, generally not more than 4 days, because if you give them beyond 4 days, there's a rebound condition phenomenon. You need to keep the patient on sinus precautions. These are very important. No reverse flow, no nasal flow, and obviously you need to control the post-op infection with antibiotics. The perforation repair is possibly a little easier in diseased mucosa, but obviously if you have a perforation, they would increase the risk of post-operative complications. You can have wound dehiscence, showed you a case, sinusitis. Generally with pharmacological therapy, it becomes beyond a reasonable level. You need to refer this to ENT specialists who are very good at treating this. We also treat sinuses, but we treat sinuses secondary to odontogenic infections. So you need to give antibiotics and decongestants. In severe cases, you might have to debride everything, take out the bone graft, take out any possible foreign body, and then possibly do a closure, which is double layered, which has buccal pad of fat, so that there's no wound dehiscence, there's no post-operative oroenteral communication or oroenteral fistula. So coming to the rounding up, it's a very predictable procedure. It's a safe procedure if you do it patiently, if you do it nicely. But I think the key feature is the preservation of the sinus membrane. Please do not get trapped by somebody who tells you that you make large perforations through careless approaches and then put a PRF that works as a magic wand. This might again work in the hands of some very talented, able, experienced surgeons. For an average surgeon like me, it would not work. So you would need to choose a procedure that is reliable, that is predictable, that has a sound scientific basis. And preservation of the sinus lining is clearly the most important technical aspect. You can do this with a lot of patients. It's basically the environment which is richly osteogenic because of the periosteum and because of the inside of the bone that makes most bone grafts tend to work very, very well. There is little sound evidence, certainly nothing statistically significant if you were to use a PRS or if you have to use a barrier membrane laterally to guarantee success in case of sinus lift. I thank you for your very patient listening, and thank you for bearing with this boring talk. Thank you very much. Okay, thank you very much. All right, so I'll go on to the questions, and I think the AIM phenomenon, the construction is such that I'll have to see the questions ourselves. I'll go on to the questions. Pre-operatively. So, all right. So that's the first question that I'm answering now. And so how do you try to prevent sinus perforation? You need to make sure that Ideally, you should be using a diamond burr if you're using a rotary instrument. Otherwise, you'd use piezo and get adept at using it. Secondly, there's a lot of variation in the cortical bone thickness. So you just need to make sure that it's a paintbrush approach. You do not perforate into the sinus. You just rub this over the sinus when you're moving bone. And obviously, diamond burrs and a straight hand piece are better than using stainless steel or tungsten carbide burrs. And obviously, you try to do most of the membrane reflection in a direct vision. You typically start from the top, then go from the posterior, then go to the top, then go to the anterior, and then go to the floor. You try not reflecting it from the floor till you have sufficient laxity of the membrane. If you do not have sufficient laxity, you try not to reflect the membrane. So these are some of the answers, but I think patience is the key. You cannot do this quick. I've reached this conclusion. And typically, I did not have, interestingly, perforation in the first 10 cases of ours, and we are in the process of doing an audit for close to 125 cases now. And then I had a series of perforation in possibly the case number 10 to 20, about 3-4 of them. And then I realized that I was trying to do it fast. So I think patience is key. So Muhammad Shahid asked that the voice was not clear, and how do you treat perforate the perforated membrane? Small perforations do not require treatment. When you start reflecting it, you need to make sure that you go around the perforation so that you do not enlarge the perforation. And once you reflect the membrane big time, it generally would fold onto itself. If there's a moderate perforation, you can possibly try to suture it if you are sufficiently skilled. If there's a larger perforation, you can use a collagen membrane, but again, just inserting a collagen membrane is not enough. You need to have a mechanism, you need to have tissue tacks, you need to have a screw. So, just putting a membrane on top of, on the base of the sinus is not enough. You need to make sure that you have you immobilize the membrane. Now, it is very difficult to immobilize the membrane there unless you have the specialized tissue tacks available. I would abandon the procedure if it's anything more than anything 6 or 7 millimeters. Call me a coward, but I think that it is statistically significant. Larger perforations would cause graft failure and would cause implant failure. So, Shakir Saab, you can contact AIM Academy. They would know if you can. They can give you the recorded lecture later. What happens if I do not know? Muhammad Yunus Baloch asks me, Yunus Bhai, I hope you're fine. I do not have, again, an experience with basocortical implants, so I think it would not be prudent to me to give my opinion. But generally, a small perforation with something which is not small particles that go within the sinus, and it's a stationary implant, would cause lesser problems. And it's very typical. It's very typical. I mean, I'm basically lazy, and I would not want to do a sinus lift for a 2 or 3 millimeters of implant entering into the sinus. It does not mean that you end up putting a 7.5 implant in a 4 millimeter of residual bone height. We are talking about something like a 7 millimeter of bone, and then I put a 10 millimeter bone. So nothing happens if you go 2 or 3 millimeters into the sinus. But obviously, you need to have enough residual bone height. Dr. Sufyan, we have already answered this, so we'll go on to the next question. Well, I can only apologize that my voice wasn't clear. So I think, again, you'll have to contact the AIM Academy and ask them for a recording. Thank you. Whether it reached. So the next question is from our dear friend, Dr. Asif Nazir, Professor Asif Nazir, and this is about the after treatment of the sinus infection. How much time can you go for a sinus lift procedure? I think if it's an acute active infection, I would want to wait for about 6 weeks before I think about going in again, at least 6 weeks. But if it's chronic inflammation and if the pharmacological therapy has worked well, I can go in as early as 2 weeks. It really depends on if there are symptoms and if there is acute infection or if it's just possibly silent chronic infection. Dr. Athil, I do not have a lot of experience. Again, I am a surgeon, but I am a coward surgeon. So yes, you can possibly potentially do a sinus lift in a sinus lift that has been repaired. If the sinus lift was double layered repaired, it would be easier to do it, but it would require a very nice sharp dissection to make sure that you have enough thickness of the flap and you do not perforate the sinus again when raising the flap. And this is a common common problem. So if you have to raise a flap, you have to possibly go partial thickness where you had a prior perforation. So I haven't done this, but I'm sure that there are people who do it. And I think the key is to raise a partial thickness flap over the repaired fistula, because even if you repair the fistula, there will be no bone formation there. So as soon as you will take your elevator to raise a full thickness flap, it is going to get perforated again. So you'll need to go partial thickness. Partial thickness means sharp dissection with the blade there. Again, I am very conservative. Radiotherapy is in my hands is an absolute contraindication to do, especially any kind of an elective work. I would even take out teeth very, very conservatively in patients who had radiotherapy. Implants are elective procedure. I would not want to do this. The kind of radiation that we actually have here, which is the megawattage or the ortho-wattage external beam radiation, which kind of burns all the areas of interest. It might not be prudent to go for an implant. You can try it with the hyperbaric oxygen. There is not sufficient evidence. You can use this with growth factors, but I would not want to do this, and I would not want to do it in the case of IV bisphosphonates and some of the anti-angiogenic drugs history also. So how do you decide between internal and external approach? The most important factor is the residual bone height. If it's anywhere 4 to 5 millimeter or more, you would want to do an internal approach because it's quicker. And if you have the newer apparatus, it's atraumatic and it's very conservative also. But anything more than that, because 4 to 5 millimeters of residual bone height, you can raise it further. Excuse me, 5 to 6 millimeter, put a decent length, 10 millimeter of implant. Anything more than that, you would require an external approach for this. Secondly, if, for example, you have to place an implant in the second premolar area, in the first premolar area, and the first molar area, and the second molar area. So instead of doing 3 internal sinus lift, you might as well do a more predictable external sinus lift. There have been some studies from good centers from North America that have suggested that there can be as much as 50% of perforation rate with internal lifts, even if you use a fancy balloon or something. You need to fracture it somehow, and then only then you'll probably not need to tap it. You'll need to fracture it through a mechanism. Now there is as much as a 50% chance. So wherever there's a risk, there are adjacent implants. There is a residual bone height of 5 millimeter or less. probably need to go for an external sinus lift. Shahzad Bhai, I do not know what is turned off. I was turned on, so I hope that it started to work for you later on. So I think we have answered questions. There are new questions, so I'll go there. Okay, so the question is that after external sinus lift, the decongestant and antihistamines are prescribed for how long? There are obviously caveats and there are problems with using either of them. Now, with decongestants as a policy, you should try to avoid them beyond 4 days. So generally 3 to 5 days should be sufficient because there's something which is called nasal medicamentosa or rebound congestion. So they are basically meant as decongestant, but they cause rebound congestion, which is very difficult to treat afterwards. So 4 days of about decongestants if they're needed. Antihistamines also have problems of, I mean, even the less sedating antihistamines are still sedating, so you don't want to take it on from forever. So I like to give them for about 3 to 4 days, and then obviously they work for another 3 to 4 days, remain working for quite some time. So Dr. Hasnan asked if I've used the auto bone graft. These are expensive machines. I do not have it. In a sinus lift, everything would work. We use an allograft because there's no evidence that it's even a lot inferior to autograft, which is the gold standard. And it's possibly a little better than xenografts and certainly better than allograft, but everything works in there. So I'm sure that the dentinal grafts would work, but since I do not have the machine, I haven't used it. Again, CGF, I've talked about this, so you can call this the magic wand or something. If you do not save the membrane, the only advantage is that if you have perforated the membrane of using a CGF, which is the other name for an LPRF, or the two parallel nomenclature system for the PRF substitutes. Now, if you use the CGF, for example, even if it goes into the perforation, it will not cause a problem. If you use a bone graft, it will go into it. It does not mean that it will make more bone. The nicely lifted membrane will make bone. This is something that you need to clarify for yourself. So I haven't used CGF. There is quite a bit of data that now suggests that CGF might be prohibitive for bone healing. Again, I know that there are many proponents who might be here also, but CGF alone is even considered to be prohibitive. It's excellent for soft tissue healing, very, very nice for soft tissue healing, but I'd be skeptical in using it to promote bone healing. So generally 12 millimeters, but in my hands 10 millimeters. If I'm doing a sinus lift, then I might as well, an external sinus lift, I might as well place a 12 millimeter. But there's no fun doing anything if you are not able to place it, unless the starting residual bone height was 1 millimeter and then you raised it about 12 millimeter, then you lost about 2 millimeter of it, and then you can put a 10 millimeter of implant. But otherwise, if I have the typical 3-4 millimeters bone that you generally have, I would want to go for a 12 millimeter implant in most cases, external sinus lift. For internal sinus lift, 10 mm. Beyond that would be it's not really judicious. It's not really needed, because if you, for example, have to put a 12 millimeter after internal lift, you might as well put a 10 mm or with a lesser lift or a lesser risk. If we have 6 millimeter of bone, should we go for an implant or internal sinus lift? Really depends on your hands. Sinus lifts tends to work well in my hands. There are oral surgery colleagues that now use shorter implants. I'm lazy in nature, but I would also be careful at the same time. So I would think my hunch with the long-term detail of example is using a 6 millimeter implant to support a 12 millimeter of prosthesis. So the altered crown root ratio, a short implant in the long prosthesis, um, uh, is not mechanically justifiable. As Carl Misch once remarked that uh, an integrated implant shall not fail if judiciously loaded. So obviously, if you load this unjudiciously, there would be long-term consequences. So again, I cited studies that have shown that there is no difference between short implants and obviously when you talk about short implants, they have to be somewhat thick also. So you need to make sure that you have enough thick bone. But short and medium term, which is 4 months and 2 years, they are equally good as a sinus lift with longer 10 or 12 millimeter implants. Long term, we need to have more data to get convinced if short implants are as good. Okay, so if everybody has left already, but there's a question from Dr. Farouk, which he has put in the chat section. So generally, you go 3 millimeters from all boundaries. So I think that's difficult. But if it's too posteriorly, then you don't need to go there because you don't need to reflect it from there. Even if you do a very large sinus lift from the top of the third molar area, there's no point in putting a bone graft and subsequently placing an implant. So this is it. So thank you very much. I thank you once again, everyone.